we have a very full agenda and a lot to talk about. So welcome, everyone. If members can find a seat, we'll go ahead and call the meeting to order. DJ, please take the roll.
Senator Rocky Adams, Senator Berg, Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Herron. Senator Mills. Senator Nemus.
Present.
Senator Rawlings. Senator Richardson. Senator Tishner. Representative Bratcher. Representative Bray.
Present.
Representative Burke. Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Dotson. Representative Duval.
Here.
Representative Fleming. Representative Gordon. Representative Holloway. Representative Marzian. Representative Neighbors.
Here.
Representative Proctor. Representative Rayburn. Representative Raymer.
Here.
Representative Riley. Representative Sharp.
Present.
Representative Wilner. Co-Chair Meredith.
Present.
Chair Mosier.
I am here. Okay, we have a quorum established to do business, and I'd like to once again welcome everyone. And the first thing on the agenda is approval of the minutes. Do we have a motion to approve?
Motion to approve minutes.
We have a motion. Second. Any opposition? Okay, hearing none, the minutes are approved. The first thing I would like to jump to on the agenda is consideration of the administrative regulations. We do have one regulation which has a committee amendment, and I would invite the cabinet to come to the table to discuss 900 KAR 6075E, please. Thank you. Please identify yourself for the record. And if you could just walk us through what this amendment does, I would appreciate it.
Yeah, thank you very much. Hi, Wesley Duke. I'm the General Counsel for the Cabinet for Health and Family Services. And this is our agency amendment on the non-substantive review regulation. And this merely changes, we had made a first change of making the neonatal beds, making them subject to non-sub review. But post-comment, we have decided to remove that, and they will currently be subject to regular review as always. So it reverts back to previous.
Okay, and as I understand it, this is 4 neonatal ICU beds per agency.
That's correct.
I see. Okay. Yeah. Is there any discussion on the agency amendment? All right. Seeing none, is there a motion for approval of the agency amendment? Okay, do we have a second? Thank you. There's a motion and a second. All those in favor, please say aye. Aye. Any opposed? Okay, the agency amendment is approved. Thank you. Thanks so much. And so for the rest of the administrative regulations, everyone should have received summaries and links to the regulations. Is there any discussion? All right, seeing none, I move that those are reviewed. Okay, thanks so much. Okay, the first presentation is a discussion on the September 20th report on how Kentucky failed to prevent over $800 million of Medicaid waste. I would like to invite Auditor Ball to the table, please, and any guests that you have with you. Please introduce yourselves for the record and go ahead and proceed. And I just first want to thank you for your work on this as we are looking critically at Medicaid and how to preserve our safety net. I really appreciate your hard look at where we may be falling short. So thanks for being here, and go ahead and proceed.
Thank you, Madam Chair. My name is Allison Ball, and I am the Kentucky State Auditor. I have my General Counsel, Alex McGarrah, on my right over here. And I'm going to try and make a lot of details simplified, so that way you just have a good overview. And if you've got any questions, we can dig deeper into things. This is about a 50-page report, which may sound like a lot. Our last KDE report was over 500 pages, so in our world, this one's actually a little bit small, but it is a little bit difficult to comprehend as you're reading through it. So I'm going to go through and kind of give you a background. As you said, the amount of money in this is a large number. It's $836 million of concurrent Medicaid capitation payments over the period of 2019 to 2022. Now, what that means is these are payments that were made for Kentucky, and also they were made by another state as well. So you have dual payments, and just kind of by way of background, I'll walk us through that a little bit. That's what is at issue here. To be clear, the $836 million, it's unclear exactly where these people were residents of, whether they were Kentucky or somewhere else. We just know that there were two states paying for, at least two states, sometimes more, paying for these individuals. Again, by way of background, how we got started on this, actually it was towards the end of the Biden administration. There was a request to a few states to look at these capitation payments that were made concurrently, so multiple states making concurrent capitation payments. So the Biden administration actually approached the auditor's office as well as several other states at the very end of Auditor Harmon's term. So when I came in, there was an agreement set up to begin to look at this, and then we were the ones who were tasked with actually doing the work of looking at it, and it's a valuable effort, and one that we were really happy to pursue and go through. I know that you know this, but Medicaid is a taxpayer-funded program that was established in 1965. It provides financial assistance to certain low-income individuals and those with disabilities to get medical care. There's about 1 in 4 Kentuckians who are currently on Medicaid, so it's a big number right now. And the total amount in Kentucky is about $16 billion of taxpayer money from Kentuckians paid. There's always federal money that goes into Medicaid as well as Kentucky's money, so both of those things are at issue. And kind of interestingly, the way it's set up, there's federal requirements. They set a baseline of income and residency, and then Kentucky has the ability to sort of go above and beyond and just kind of spell out some things. So there's an effort from both sides that go into this. The Department of Medicaid Services is the one who's tasked with administering Kentucky's Medicaid program. Now, in Kentucky, most of that is outsourced through contracted MCOs, and that's actually the beginning of how this happened. So you have MCOs. There's really two ways to do Medicaid payments. You can do a fee-for-fee model in which the state directly pays providers for covered Medicaid services. The second way, which is the one that's used mostly in Kentucky, is to outsource payment management to managed care organizations, MCOs. These payments to MCOs are referred to as capitation payments. Now, capitation payments are made based on the individuals who are enrolled. It's very distinct from the fee-for-fee. So, like if you're a fee-for-fee, you're billing the services that were provided. This is sort of a payment that makes sure you're covered if you are a Medicaid recipient. So it's important to understand the two distinctions. Again, we looked at January 1, 2019 to December 31, 2022, and you'll quickly pick up that covered the COVID years. So a 3-year period of time. That is relevant because there was some change in the law during that time that wanted people to stay enrolled if possible. However, there was one exception that was very, very clear about enrollment, and that was if you were a non-resident of Kentucky, then you were not eligible anymore. You might be eligible somewhere else, but you're not eligible in Kentucky. So the Commonwealth of Kentucky was supposed to be reviewing during that time period, making sure everybody they're paying for is in fact a Kentucky resident. Now, there's different technology available to find out if you're up to date on residency. One particular use of technology is called PARIS. That's the Public Assistance Reporting Information System. This particular data system is the one that is used by Kentucky. It was used during this period of time. It allows for an interstate match function that can detect concurrent enrollees, and then it sends an alert if it detects that somebody is enrolled in more than one state. So that's been something we've been a part of. It does have some pretty major limitations. It's not updated by every state. It has something of a voluntary involvement to it. So it's not always up to date. Your data, your tools, and your frequency are not at the level where it really needs to be in order to be able to keep on track of this. And it's also done quarterly. So you have to wait for a while before you get information, and the information you get, you look at it during that time period. So it's difficult to go back and find out, well, what happened prior to that quarter, et cetera. There's another database that is better, and it's TMSIS. Stands for Transform Medicaid Statistical Information System, and that is a better one. It's more standardized. It's up-to-date data. All 50 states, including Washington, D.C. and the U.S. territories, have to put in data into that on a monthly basis. It's one that would be very beneficial to us if we could have access to it. This is actually what we used when we were conducting this audit, because we were given special permission to use this, and it really revealed that this is a tool that would be extremely beneficial. Up to this point, states can request limited versions of this. TAF is the limited version. However, it excludes personally identifiable information. And so that does make it less helpful when you're trying to keep up to date about who's a resident, where do they live, what's going on and all of that. So one of the things that we're going to be recommending in this is to get this full access to this database. I actually do think that this is important, this is helpful, and the Trump administration has made indications that they would be much more willing to allow states to have access to this. So bear that in the back of your mind. I think that's something that needs to be addressed in the future, just full access or better access to this, or perhaps some kind of agreement where we could have information more easily. But currently we use this Paris system, which sends alerts, and then you can go and you can review things, but its usefulness is primarily for the alerts that you get that tell you, hey, somebody has been enrolled in another state as well. We looked at the MCOs to try and figure out, okay, well, you have these concurrent payments. Is there something that could be done at the MCOs that could address this issue? And it does appear that there could be something done at the MCO level. We looked at 11 contracts with our MCOs, and we found that there was nothing in the contracts that would provide for a way to get money back if there's been concurrent payments. So that is something that could be addressed, probably should be addressed, and that puts some initiative on the MCOs to also be policing this as well. Another issue that we reviewed and determined is that they don't have, for the most part, any reason to take initiative. There are some requirements generally that if they know about fraud, if they know about waste, then they need to report it and tell us that. And that's good and that's helpful. But there probably needs to be a greater level of partnership with MCOs, because we have tasked them with this responsibility. They were given agency in this setup. So that's something that I do think that should be addressed probably going forward, is that they should have some initiative to be able to review, to check, and make sure all these things are up to date. I've already laid out there's more that we can do with the federal government. We could have access to the TMSIS data. The Center for Medicaid Services would be the one to help us be able to do that, and there's been some indication they might be willing to do that. However, there's quite a bit that happens in the background for CHFS and the particular agency that's in charge of Medicaid, not agency, but the department that's in charge of Medicaid. And I'm going to go into that a little bit more. So we have this technology issue, which I think has some paths forward. We have these contract issues, which have some paths forward. There's some internal behind-the-scene things that I'm going to dig in just a little bit more in depth. And this is where I think some of our real issues were. Some of this is very simple. Just beginning at the top, we conducted a lot of interviews as well as reviewing what training they received, documentation that's provided to make sure people know how to check on residency. What are you doing to make sure that this is being caught? And we found that there was an attitude from the top, and this came up with leadership as well as employees who are boots on the ground going through this, is that there's been a general attitude of, especially during COVID, but it maintained the whole time, don't bother looking at this. This is very low priority. If you've got the time, fine, but for the most part, don't bother looking at it. We have actually direct quotes from interviews, both leadership and boots on the ground, saying this is a low priority. And of course, if it's a low priority, then it is in fact a low priority. And it results at some point in $136 million that have been spent that shouldn't be spent. So step number one, there needs to be an attitude from the top all the way down. This is, in fact, a high priority. These are taxpayer dollars that are being utilized for this. This is something that needs to be addressed in a very, very clear way. It's not just the tone, though. They need to also be given training and instructions for how to do this. And we found there was a lack of written procedures and training to make sure people know what to do. In fact, we were told that mostly they relied upon a 2018 memo that was last prepared in the Bevin administration. So something that is probably outdated by this point in time. It's pretty old. There were some high-level documents contained in some things that we reviewed. Most of the boots on the ground people didn't even know that it existed. And really, they told us they learned how to do this on the job. So if they happened to talk to somebody who had done it before, if they just figured it out on their own, it's just something that just sort of happened as they were going through it, which is consistent with the attitude of this isn't really that important. Don't spend a lot of time on it. If you get to it, fine, but it's low on our priority list. We also found that the actual process itself internally really works against researching this and finding out about this. Without going into a whole lot of detail, and we could if you want to, and it's well worth going into at some point in the actual report, the way to actually do this is not simple for them. So there was an idea that, well, it's very siloed, for one thing. The people that work on this are very, very siloed. You don't have a caseworker assigned to a particular individual. You have different people assigned to different aspects of this. And so that leads to things being dropped and missing stuff. So there was some discussion about, well, we have a goal list, and you go through these tasks and these goal lists, and then you should make sure that they're done. And there was some indication that perhaps Paris alerts were one of the things that you're supposed to be reviewing. But when we actually talked to people, that did not seem to be, that didn't come up on their computer screen as something to be able to review it. In fact, they told us the only way they could even find out if there was a notification from Paris telling them that there had been a concurrent payment was if they went to another non-financial portion of the database that they were looking at. So it's not even the regular screen that tells you your goals. You have to go to a non-financial area to click on it, and then there would be a banner on there that would show, hey, there's a Paris alert for this particular Medicaid recipient. So it would take some initiative, it would take some work, and it's consistent with what people told us about. If they happen to check on a Paris alert, it's because they stumbled on it as they were just looking through the file. There's also not a standard process for what to do when you find out that there's been a Paris alert. There's a tremendous lack of direction and information, and it goes in great detail in the report. Do you call? Do you email? How long do you wait before there's a response? Just major gaps in the process to figure out how do you get in contact with another state? How do you confirm, in fact, that they are enrolled there? How do you get in contact with the recipient? A variety of problems about the actual process itself to make sure that it's done. And this was a significant problem. If you ever click the completion box on the Paris Alert banner that shows up, well, then it tells everyone that the entire work on it is done. So you're not clicking, hey, I saw the Paris Alert, I'm going to go work on it. For all anyone knows, once that's clicked, you have reviewed it, you've checked on the residency, and they are a Kentucky resident. So going through interviews, going through the process, that was a tremendous breakdown, which could lead to multiple payments going out for individuals. All right, that is a very, very quick overview of the problem and how we got here. One of the things that we did, because we were working with several other states in this process, and that's extremely helpful because we could see how they got where they got, as well as what have they done to address it. And I think this is encouraging because this tells you there are ways to address it. This isn't a problem that can't be fixed. It can be fixed. So we looked at states like Massachusetts, and they're very intentional about using their Paris alerts to dig deeper and doing in-depth investigations. When they do that, they cross-references other data sources that they do have access to, like Accurint. They also look to see if there's MCO activity that's been recent that could confirm residency within the Commonwealth of Kentucky. And this, I think, is also key. Once they get a Paris alert, they immediately flag that individual from MCO care to fee-for-service care until they can provide proof that that person is an in-state resident. And Massachusetts himself believes that they've actually saved $65 million just by that one step alone, just shifting from the MCO at that point to the fee-for-service system. Rhode Island also uses Accurint, but they use the USPS National Change of Address database, and they use Equifax Works Number to verify residency. These are all publicly available databases. It wouldn't be difficult to get these things. It can be done. They also prioritize unresolved Paris alerts after 60 days, and they send monthly reports to everyone, as well as regular casework training. So they're taking it very seriously and aggressively. Oregon has shifted from if they get a Paris alert, they go for the fee-for-service, and they incorporate the federal do not pay program to identify ineligible individuals. Louisiana uses the Interstate Driver's License Compact and the National Provider Identifier Registry. That's an interesting thing that might be helpful too, because you're kind of enlisting the use of provider information. There is an area, I think, for MCOs, because there aren't very many MCOs throughout the nation that do this. So there probably is a greater way to be able to find out just from the MCOs, are these people within the Commonwealth of Kentucky or not. Ohio uses driver's license data, and they also move individuals to the fee-for-service coverage, and they are very serious about doing proactive whenever they find out that someone has not accessed services for a long period of time. That's a trigger for them. If you're not going to the doctor, that may mean that you're in fact not here. Illinois, Washington, Minnesota have also suggested using other clearinghouses. Washington, Minnesota said that they used the SNAP clearinghouse and the Social Security Administration information to assist to find out true residency. So this is not a hopeless situation. It's not something that can't be resolved and can't be fixed. There are other states that are addressing this and doing this. So there's internal things that need to be addressed. There are databases and systems that can be utilized. It is an entirely fixable problem. But that is a good overview of everything that's on it. I can go into some more in depth if you want to look at the actual numbers of some things. But we actually took the time, since we had access to this federal information, to actually pursue two more things that I think are just worth mentioning to you all. And this is not included in the $836 million. But there are two other areas of breakdown. And one of them is a subset. So again, this is not a big part of our report, but it's included in it. We look to see if we're making capitation payments on behalf of deceased beneficiaries, and we found that, and this was a small sample size because we were just sort of figuring out, is this a problem, is this ongoing? We did a sample size of 19 deceased individuals, and that we found that capitations were made after their death for at least 4 months after the death, and in some cases as much as 2 years. One of those 19 was 857 days. So that's a pretty significant breakdown. The average delay for recording death in a case file was 319.5 days, and payments continued on average for 205 days past the day of death on average. We do utilize the KVETS document or database to be able to see if someone has passed away, but it often fails due to mismatches in data, and then a lot of it requires manual review by caseworkers. So we need to do a better job actually digging in to see if somebody has passed away. I think that's something that's worth mentioning. We actually also found that of those 19, some of them were having concurrent payments from other states. So you had the double problem. You had the problem of that they've in fact actually passed away, and then also other states were paying for them as well. And then there was another subset, which is actually worth mentioning because I think it just compounds the problem. We found that there were 100 or more concurrent payments for over 4 years for certain individuals. So that means you had multiple states totaling up to over 100 payments over a period of 4 years. And I know that sounds a little confusing, but I'm just kind of trying to help you with it. It just shows you sometimes it's not 2 states, it's multiple states for individuals. So we had at least one individual, and this was another subset that we reviewed, that had 8 states that they were signed up for. So we absolutely need to get a handle on this. It is a total waste of taxpayer dollars. It's always worrying whether it's federal taxpayers or state taxpayer dollars, but I think that we have a great responsibility to check on those taxpayer dollars that are coming from the Commonwealth of Kentucky in particular, and this needs to be addressed, and we got to get on this one right away. It's worth noting, again, it's a certain period of time. It's 2019 to the very end of 2022, and the Department of Medicaid Services did contract with 50 individuals. They were telling us at the time they were going to contract with 50 individuals dedicated to dealing with the Paris backlog. And they were provided documentation for how to correct this problem. And that came up a little bit in the interviews. It's outside of the time period that we reviewed, but it did come up that is something that was being put in place. And I don't have information on the progress on that one because that kind of like got swept up at the end of what we were reviewing. They told us that they were going to be hiring these people. They were going to be contract workers, so they weren't people within the system necessarily, but they also were going to be using documentation that's different than what's been provided to the people that are boots on the ground that have been doing this for a long time, and none of the boots on the ground people had access to that information that we discussed. So that is a quick overview. I hope that was simple enough because this actually got pretty detailed in the report, and we can go into a deeper level if you want to.
Yeah, thank you so much. It is a big report, just a lot of information. It's hard to even know where to start. Thank you for your recommendations about the technology changes, the oversight that could be happening from the MCO perspective. I mean, it's mind-boggling to think that someone can enroll in 8 different states. Gosh, I mean, are they moving that much? And then, you know, the fact that they are automatically put into this capitated system where these premiums are automatically paid. It just seems like that piece really could use a major overhaul. So I know we have a few questions. My burning question is there any opportunity to recoup any of this money that we found?
So we asked that question too, and that was one of the reasons why we spent quite a bit of time reviewing those contracts, because in our mind, that was the path forward to be able to recoup the money. And there was nothing in those contracts that provided an agreement to get the money, because the money's been sent to the MCOs. And there was nothing in there that provided a basis for us to be able to get it back that we could see. So at this point, we did not see a path forward. Now, you know, this is an audit, not exactly a legal document. So it may be worthwhile for someone to spend some time reviewing that and trying to figure out if there's a creative alternative solution. But when we reviewed it, because I mean that was one of my first thoughts: is there a way to get this money back? And from the contractual standpoint that we have with the MCOs, we didn't see a path forward. I can even refer that over to my GC for a moment and see if he's got anything to add to that.
If I was trying to be a clever attorney, Chairwoman, I would try to pursue an equitable theory, unjust enrichment, maybe, some kind of quantum merit claim. That I'm just throwing that out there as my thoughts about this. Maybe that's possible to do.
Okay. Clever attorneys can come up with clever ideas.
Yeah,
yes, this, yes.
Okay, all right. Well, thank you. We do have a few questions. I'm going to ask members to keep them as abbreviated as possible. We've got a busy agenda, so Representative Fleming.
Thank you, Madam Chair. Auditor Baugh, I want to express my deep appreciation for your willingness to go through and doing this audit. I have gone through your audit not once but twice, and I got a bunch of questions, but I will not go through in the interest of time. But I would like to sit down and talk with you a little more about that. I think you exposed basically a strong evidence of the lack of oversight from a managerial and financial management skill set that exists within the administration, particularly when it comes to health and family services. That's really disturbing. You've only touched one aspect of that, and I want to ask you, to your knowledge, do you know if there's been any other audits that has been conducted with the DMS or any other divisions within DMS to go through that process?
Yes, so we do conduct SWAC from the auditing office, my office. We conduct that every year, and that does touch on some things that deal with Medicaid. So that's a recurring audit that happens by statute every single year, and we actually we made that public, some of the findings that related to this earlier this year. It's been a while now, so probably many of the public has forgotten it. But we did address some other areas of concern that we had at that point in time. One of them was not having verification of a person's citizenship and eligibility to be able to receive Medicaid. We found a problem with that when we were doing a sample size. We also found a problem with people using the same Social Security number And so we found at least, it was a small sample size, but we found at least 2 people that were using the same number twice. So there was like 4 people. It looked like 4 people, but it was actually 2 people because they used the same Social Security number, which showed that their internal controls, that I think there's technological controls that they had set up, didn't catch it. So there's some other areas of concern. I believe that probably is what you're getting at. Is it just this, or are there other issues too? And the answer is we know from SWAC that there are other areas of concern as well.
And I think there is, based on what we're looking at. And first of all, I want to also express on behalf of Senator Adams that we do appreciate it. We know you're double duty today. You're going to come before the Medicaid Oversight Board. We have some additional questions with that as well. But was there any other perspective in terms of the contracts with the MCOs, with the DMS? Because what I can gather on page 14, the Kentucky's ability to recoup these MCO contracts were not addressed contractually. And then on 35, he said estimated Kentucky made unnecessary payments of $2.7 million. To me, that's an utter failure in terms of managing contracts, auditing the contracts, and working with the MCOs in order to do their job. Because I can't find any evidence where money has been recouped or any effort from the DMS to go through and work that MCO's contracts. So that's really, really concerning, and a lot of people don't know about that. I want to make sure this committee is aware of that and doing that. Like I said, I can go on and on, but if you have a quick response, and I'll just go ahead and back to the chairman.
No, I think those are very good points. I mean, we entered into those contracts to begin with, so we have a duty to make sure those contracts provide a way forward if something like this were to happen, and they also have to be monitored, and there are times that you can amend contracts. So I agree, there's an oversight issue on the contracts themselves.
Okay. Thank you. Senator Carroll.
Thank you, Madam Chair. And I see issues with the MCOs. They are very good about taking money, not so good about giving it back. Auditor Ball, so I'm clear on the amount. So the overall total is over $800 million. Kentucky's loss is 318 approximately.
So it's hard to say. Actually, it could be more than that. And the reason why I say it's hard to say is because this particular audit did not include the extra step, and there are reasons for that, of finding out where these people actually live. So it's possible that all these people lived outside of the Commonwealth of Kentucky, and if that's the case, then it's the full $836 million. Could be half of them. So that's the reason why I can tell you with great confidence that this number shows that there were double payments for these individuals. There should not have been double payments. Where they actually lived, I don't know, because that wasn't pursued by the Commonwealth of Kentucky during the period of time. And at this point, it would take. We don't have access to that kind of personal information for individuals. We would probably really need DMS to actually do the work to find out.
And I had noticed this problem as a provider, where living on a state line, where we would have folks from living in Illinois, and then we would discover that they were drawing Medicaid in Kentucky. So I see that. And I can't imagine that the MCOs, this should be something very simple that they could build into the system to catch this. But obviously, there's no incentive for them to do that. But I appreciate your work on that. Thank you.
Thank you, Senator. Next, we have Representative Camuel.
Thank you, Madam Chair, and thank you all for being here today and for sharing the information. It was a lot to take in, and really mine is more of a comment and observation after reading through the material. One is I wish that we had Dr. Stack here who could then actually, participate in the conversation about this. But what it seems like is Medicaid's a federal program, and they've got their technology set up, their databases. It seems like this could be resolved at the federal level, like with a little bit of extra work, making sure that any changes to individuals who are enrolled in Medicare, to make sure that they aren't receiving it into speeding up the time that the communication, the data is rolled out to the states. Because Kentucky's not unique. This is happening everywhere.
No, Kentucky's not unique. And that's one of the reasons why I went through a list of the other states and what they've done to address it, because I think that was beneficial. And if you'll notice, most of those were blue states. So so it's doesn't matter the political party or where your background is or what your alliance is with any particular administration. There are other states. It is true. Most states have had this issue. Other states have, I think, taken a greater initiative to resolve it. And you're right. There is a federal component to this, but the way it's been set up is that it's a federal-state partnership. So unless there's a dramatic change in the law, the states have a pretty significant role, and they actually defer to us quite a bit. Like they set a baseline about what income, residency, those baselines, but we then have the discretion to be able to add a lot to it. And I think with that discretion then also becomes responsibility to make sure that you're maintaining the program the way that you're supposed to. So but I do agree to your point. There's more that can be done from an information level, from the federal level, and that's one reason why we spend a lot of time talking about there are these other databases, and I think it would be helpful to have access to that.
Absolutely, and I appreciate that because 50 states coming up with 50 databases that aren't communicating is a problem. So thank you.
Okay, and it does sound like you had some conversations with the cabinet and leadership to try to get some answers about why this wasn't being addressed. So just wanted to point that out too. Okay. Senator Meredith.
Thank you, Madam Chair, and thank you, Dr. Ball, for your report. Very simplistically, this looks like it's a situation where the oversight is everybody's responsibility, which becomes nobody's responsibility. And I think we've abdicated a lot of things to the managed care organizations that we assume are being taken care of. They're not. But I wanted this particular function of oversight, whether perhaps we need to consider with Moab, Co-Chair Fleming, to privatize that function. Because again, unless we have a contractual obligation with somebody to do this, I don't know how within the cabinet itself it can ever be as aggressive as it could be or should be. Do you know of any states that have taken that measure?
Yeah, I believe, and I'd have to do some more background to give you exact numbers, but I believe there are some states that have done the fee-for-service system and not done the MCOs at all. And I've got a number in my mind, but I don't want to say it because unless Alex remembers, because that's not something I have off the top of my head. But this isn't the only model. There are other models that other states have pursued.
It's music to my ears. Thank you. Yeah. And again, because of the very nature of the contract, the MCOs, unless there's a specific provision to do this, they have no incentive to do this. Because for every dollar that they save our Commonwealth, they lose 10 cents. So that's why we need to look at some other alternatives. But thank you. Appreciate it. Thank you, Madam Chair.
Yes, thank you, Senator. Senator Julie Rocky Adams.
I think Senator Meredith and I share the same brain because that was actually my question is contractually, can we move into a fee-for-service model with what we have in Kentucky so far? So thank you.
Thank you, Senator. And I just want to point out that I heard a comment that was scary, that you share a brain. Just kidding. Okay, last question. Senator Nemes.
Thank you, Madam Chair. I read the conclusion of Dr. Stack, and he disagrees with all of this. So when you were asked, have you worked with them, it kind of sounds like they say we're not doing anything wrong and we're not going to change. We're not going to try to recoup the money or not. And then also, do and can the MCOs verify residency? Could that be a contractual thing that they have to?
Yes, I think they could.
How about the first question?
Oh, about the involvement from Dr. Stack. Well, and you have to remember, Dr. Stack is fairly new to this. So in fairness, most of this was his predecessor. So like, for the full understanding, most of it didn't apply to him. He came in at the tail end, and he didn't cover any of the period of time that we reviewed. But you're right; that has been the sentiment of that's the way I would have read it as well.
Okay, thank you, Senator Berg. Do you have a very quick question? Thank you.
Thank you. I really appreciate the opportunity, and I apologize for being late this morning. Personally, do you have a preference between an MCO model of delivery and a fee-for-service model of delivery for this state's Medicaid program?
Yeah, that's a good question, and I'm really mindful of what our area of expertise is and what yours is. So what I've tried to do is lay out, this is how we got here, and these are possible fixes. But then I'll leave it to you to do the policy analysis to figure out what is the best for the Commonwealth of Kentucky. There are some hybrid approaches that some other states have used, and in my mind, that's a pretty good way that's helped other states. So I think that's worth looking at. So I just wanted to mention that because it's not necessarily an either or. Some of those states said if you triggered a Paris alert or you haven't had any medical services in a while, those things are triggers which shift you over to the fee-for-service system as opposed to the MCO system, which seems to be a pretty good safeguard. And I think it was Massachusetts that said they've saved $65 million, they believe, just by that one step alone. So I will just throw that out there just to say it isn't a binary choice. There is a way to sort of do the blend. And in fairness, in Kentucky, we actually do have some fee-for-services. We're pretty high majority MCOs, but we do have some fee-for-services. So there's a way to it doesn't have to be one or the other, or it could be one or the other. I'll leave it to you and your discretion and your expertise because, I'm very mindful of the fact that you're the policymakers, but I want you to have the tools that you need to be able to make those decisions.
Okay, thank you. And this is the last question. And I think in the next discussion, you're going to see some conversation about auditing MCOs. So, Representative Marzian.
Oh, thank you so much, Madam Chair. Apologize for my late last question, but and it was a very interesting report. But and thank you for all that info. Have you done any research or auditing of provider fraud? Because I've Googled some, and there's like billions in Kentucky, and I think it would be easier to find, number one, because Medicaid recipients half the time don't know, they're mentally ill. They don't know that they've applied in 3 states. You can't really blame them sometimes, but providers know what they're doing. And have you, and I'll have some info at the oversight committee about provider fraud, but it's like billions of dollars.
Yeah, very good. Yes, I hear that too, especially from the public. I'm from a small town, a small part of I'm from Eastern Kentucky, so we have a lot of medical providers in that area, and all over the Commonwealth of Kentucky, there's a lot of medical providers. And when you have large numbers, then you hear stories and you begin to question and wonder things. I think those types of audits are valuable and worthwhile. There would have to be certain ways to be able to do it because they're massive tasks, big tasks. But I agree that that's an area that needs to be reviewed as well.
Yeah, if we could clamp down on those, we could probably recover a lot of money. But thanks much.
Yeah, thank you. And I would like to, on that point, really look at credentialing and ensuring that the providers are adequately credentialed to bill Medicaid. I think that's really the issue with providers, because providers are actually only paid once for the service they provide. So just to clarify that, and I am looking at that. So. Okay, thank you so much for your work and for your presentation, for indulging all of our questions. I'm sure that we're going to have more as we proceed, but I'd like to follow up on the recoupment possibility, and certainly we'll take your advice on the recommendations for technology and so forth.
Good. Thank you, Madam Chair.
Yes, thank you. Okay, next we have a discussion on the 2025 regular session House Bill 787 and the proposed changes. And as you will see, this is right in line with auditing, giving providers the ability to better work with MCOs. And maybe there are some things that we could even add to this from the previous conversation. So if you can introduce yourself for the record and proceed, we will get going.
I'm Michelle Sanborn, president of the Children's Alliance. Thank you, Chair Moser and committee, for allowing me to speak today. I've prepared some remarks, so I'll stay within my allotted time frame here. In the 2025 session, Chair Moser introduced House Bill 787, and she's pre-filed this bill for 2026. This bill is a critical piece of legislation aimed at creating efficiencies in the Medicaid managed care system and ensuring transparencies when the MCO's audit and appeals process. Kentucky's healthcare providers are burdened by an administrative system that is cumbersome, it's inconsistent, and it's often unfair. Instead of focusing on patient care, providers are forced to navigate unclear and arbitrary rules, excessive audits, and an appeals process that is anything but transparent. Let's see, we're going to push those out so you can see those as we the providers have shared that MCOs can and have denied payments or claims for any reason. MCOs can and have recouped payments arbitrarily, oftentimes before the appeal process is complete. Audit process are vague, excessive, and unreasonable, requiring providers to submit overwhelming amounts of documentation in unreasonably short amount of times, and then often never hear back about those audits. Providers struggle to get clear responses from MCOs when they need guidance and clarification, and MCOs can drag out appeals indefinitely with no consequences. Providers have shared stories after stories about the challenges of working with the MCOs. However, when we spoke to providers last year, the MCO audits and appeals were one of the most challenging aspects of providing treatment to children in Kentucky. Providers reported large volumes of audits, requests, and short amount of times to turn those files in. They reported mistakes that were not their fault, yet they had to be the one to fight to get reimbursement for their services. In August of 2024, we had 9 providers report that they had 53 requests made within a week's time for 1,743 clients. So it's just 9 small providers. That's how many client records they were asked to produce. Within less than, a lot of them were in 3 days. They were being asked to give these documents over a year-long client record within 3 days. They've never heard back from the results of those clients or those audits. And you can see all the other comments here. So I just want to walk through just one example of an audit that happened last year, or a recoupment actually. The provider received a letter on January 23rd. The letter was dated the 11th. It was postmarked the 15th, and they didn't receive it till the 23rd. And the letter stated basically, and it came in a document of 376 pages, and there were at least 2 claims per page. So you're talking 700 claims. They didn't understand what the recoupment reason was, right? So they get this box of materials, they don't understand it. They try to reach out to the MCO, and they finally were told that because they called, and I even brought the letter here. They called the number on here that says if you have a dispute, give us a call, right? When they finally heard what the reason was, they were told they could appeal, which they did on February 4th. But on February 11th, they quit paying them and they started recouping the money. They finally met in person with the MCO, and the MCO stated that they could continue to appeal, but they stopped paying them. So for 2 or 3 months, that MCO, because it was a large amount of money, over $88,000, they quit paying that agency. And the agency then later had to fight to get that money back and is working to do that. So the bill specifically addresses some of these concerns that our agencies have brought up. It requires the MCOs to include current contact information for provider relations and contact representatives on their website. It requires the MCO to include their internal appeals process and process for requesting an external independent third-party review on their website. It allows providers to file an appeal related to the reduction or denial of a claim within 120 days. It establishes a penalty or fine for not meeting the 30-day time frame for disposition of an appeal. It provides clear instructions on how to file an appeal and to pay providers within 30 days after a favorable appeal determination, including 12% interest and, if applicable, attorney fees. It provides written notification to providers to include the date, purpose, and number of records requested and the time frame. It requires the MCOs to use a valid sampling method to determine the number of records requested. It requires the MCOs to give providers at least 30 days to provide records for an audit and grant additional time if needed. It establishes that audit records shall not exceed 2 years from the date of the claim. It requires audits to be completed within 180 calendar days and that notice of the audit finding to be given to the providers. It ensures that when audit identifies a clerical error, that the provider is giving 30 days to correct that error without recoupment. It ensures MCOs cannot recoup disputed funds until after the appeal process is completed. And if they do recoup funds prior to the final disposition of an appeal, they are fined. It ensures recoupment of funds should be structured in such a way as to not cause a substantial reduction in the cash flow to a provider. It adds language to the monthly report that they provide to the department, and it requires the department to provide an annual report to LRC that includes the number of appeals, the dollar amount, etc. Several of the provisions in this bill are already in statute and KRS 304-17A 741, which is audits of pharmacy records. So why would our MCOs not need to follow the same procedures for medical and behavioral health records? So as leaders in Kentucky, we should ensure our taxpayer dollars support patient care and not bury healthcare workers in paperwork as they fight for what is right. We fully support audits to prevent waste, fraud, and abuse, but the current Wild West system is out of control and it must end. We must have fair and transparent processes, appeals processes for our healthcare providers so they can spend time treating our children and families.
Thank you, Michelle. I really want to thank you for your work on all of this, the work that you and other providers have come together to alert us to. And I mean, I know providers who have mortgaged their home to keep their payroll going. So, I mean, this is, it really has gotten out of hand. We need the ability to partner with MCOs and not be penalized unnecessarily when providers are trying to provide care to our taxpayers and to our patients. So I do want to just clarify. So all of these providers are obtaining a prior authorization at this point, except for substance use treatment, which was just reinstated through Medicaid. So they've all received prior authorization to provide the care, and then they provide the care, and then they're audited.
That's correct.
Yeah. Okay. We need to put this provision in place. So, do we have any questions, Senator Douglas?
Thank you, Madam Chair, and thank you, Ms. Sanborn. As someone who's sat in that provider chair for a number of years, you hit many of these nails on the head. I had over $250,000 held twice during my practice, and the only reason I was given was, well, we're doing an audit, and the bills still come, and you still have to pay the bills.
Yes.
So this is I want to thank you and your group for moving in this direction. This is something that has been needed to be done for a long, long time, and I can guarantee you that the providers, the healthcare providers in the Commonwealth of Kentucky, will be extremely thankful to you. Thank you, Madam Chair.
Thank you. Representative Fleming.
Thank you, Madam Chair. I just make a quick statement. I just want to echo Senator Douglas. When you first laid this out in terms of bill some time ago, it was very, very well thought out. I know there's been some improvements, and I do appreciate what we've done. I just want to make sure once again that this committee understands the gravity of what Auditor Ball has mentioned, as well as Ms. Sanborn has mentioned, in terms of the oversight of DMS and the Family of Health Services, and not managing and overseeing these contracts with the MCOs and what they're trying to do. Thank you.
Thank you. Representative Sharp.
Thank you, Madam Chair. Ms. Sandberg, this is kind of timely because in the last 24 months I've had 2 providers come to me and complain about these audits. And their result is we're just not going to take them anymore. We're not going to take any Medicaid. Is that becoming a problem throughout the state?
Absolutely. Folks, they just can't keep up with the administrative burdens and craziness is really what it is that goes on. A lot of times, even some of our providers, they're audited and recouped on enough that they just can't afford to pay the staff and or an attorney to fight it. So they just settle because they just are like, we just can't even do this anymore. And it's not right, especially when it was services that were provided in good faith and have been provided, and at least give people the opportunity to appeal before you recoup the money, right? So if they've done something wrong, I'm for recouping it, but if they haven't, allow that process to take place before you take that money.
Okay, thank you. Thank you, Madam Chair.
Thank you. And Senator Meredith.
Thank you, Madam Chair. And I know I've talked ad nauseum about this particular subject, but we have a crisis of biblical proportion. We're paying 2-3 times more than other nations in healthcare, and our outcomes are terrible. And when you look at us compared to other nations, one of the biggest things that stands out is administrative burden associated with it. And I was having a sidebar conversation with Chair Moser about this. I don't know if we've ever done a calculation of what that administrative fee associated with the Medicaid program is, but based on what you've told me today and just some anecdotal experiences, I wouldn't be surprised if we're not spending over 40 cents of every dollar just on the administration of the Medicaid program. And it's probably even more for small providers and rural healthcare providers. So we have a challenge on our Medicaid Oversight and Advisory Board to obviously take a look at this. I know that we will, but I think this is where we really look at picking the low-hanging fruit. Our own Medicaid program in 2017 was $10 billion. This next budget will be in excess of $21 billion. We can't afford this any longer. And as I profess time and time again, there's enough money in the system already to take care of everyone if we spend it the right way. Yeah, I would certainly support this bill. I think it's unfortunate that we have to take these kind of actions because we're in effect creating another bureaucracy when we do this. And there's got to be a better way. There is a better way in doing this. So I hope the interested parties are listening, but I appreciate your testimony today. Thank you.
Okay, thank you. And then Senator Burke.
Thank you. Thank you for the work you're doing. Thank you for this bill. It's obviously something we need. In response to Senator Meredith, there is data that, and this is about 4 or 5 years old, that shows that the average physician in this country spends $100,000 a year on billing. That is how much money is coming out of healthcare delivery and being spent on these administrative functions that really do nothing to improve outcomes, nothing to make our people healthier, and nothing to actually fulfill the mission, which is to provide people with access to adequate health care. So thank you very much. You know, I just keep wondering, because, you know, I was in private practice for years, my entire life. I billed for my services. And you do a service, you submit a CPT code, you bill for it, you supply data to show that it was necessary. The insurance company pays you. If they want to come back 2 years later and say they paid you incorrectly, why do they not sustain the cost of that mistake? Why is that automatically put back 100% on the provider who billed in good service and did the work in good service? At least it should be split 50-50. It was their mistake as well. Thank you.
Okay, thank you. And we actually addressed that issue in the bill. So, okay, thanks so much, Michelle. All right, next we have a discussion on healthcare innovation systems and quick response teams. Welcome, everyone. Make yourselves comfortable at the table and introduce yourselves for the record, and then proceed with your presentation. Thanks for being here.
I'm Dana Malloy, Cordata.
I'm Michael Brooks, CEO of Cordata.
Good morning. I'm Dr. Kelly Firesheets, and I'm the Vice President of Strategy and Partnerships with Cordata.
Good morning, Chairs Moser, Meredith, and the members of the Joint Committee for Health Services. Thank you for allowing us to be with you today and share some information on the work that's happening within the state of Kentucky and has been happening for several years. I am personally a retired police chief from the southwest portion of Ohio, and I'm here today as an employee and a representative of Cordata to talk about Kentucky's quick response teams, their QRTs, and all the work that's, again, as I said, has been happening. But I want to be very clear from the beginning. This is a topic that I'm very passionate about, this collaborative partnerships in communities to better serve them. So if you see me looking down, it's because I wrote stuff down because they were very clear that we got to be concise, and I could talk all day about the great work that's happening in our communities. So I want to be respectful of your time. And if I look down, it's not because I don't care. It's because I want to make sure I stay on point and not get into the stories, because I could tell a story about every community that's working collectively together to get this work done. So from a Cordata perspective, we build solutions for some of the toughest challenges that are happening within our communities, from foster care to domestic violence to sexual assault to substance use to addiction to mental health. The opportunity to work collectively together to figure out solutions that make a difference in our communities. As we know, there's 120 counties within the state. There's communities that have different visions and different needs. How do we talk about it? How do we work together? How do we identify a solution? That's the conversations that we have with communities and leaders in every part of the state. These issues require partnerships, good data, and strong local leadership. When I started working my law enforcement career, I spent close to 30 years in law enforcement, progressed through the ranks. I never dreamed that there'd be a day when I worked with an organization that was as open-minded, as collective, and willing to talk about how do we work together? And then how do we take what we learn and make it have an impact on the community and the way that we serve, becoming more effective and more efficient in our services? Meaning we're not just doing the same thing over and over again, hoping for different results. We're actually looking at the data to become more effective in our response, because we know we don't have enough time, we don't have enough people, and we don't have enough money. And we have to be good about our partnerships and good about our response to get the folks the services that they need. As they shared, I'm joined by my teammates, Dr. Kelly Firesheets and Michael Brooks, and we've worked together with Kentucky QRTs since 2019. We help train, implement, and mentor teams across the Commonwealth. And we owe so much to Chairperson Moser, who was willing to listen back in 2016 to an idea and say, you know what, I believe that this is a good idea to work collaboratively, to be a partner, think differently, change the way we do business. And that helped launch the first QRTs in Northern Kentucky in 2016 and 2017. So it's grown since then to a point where now QRTs are serving over 41 counties in the state of Kentucky. But a quick response team, so you know we're all on equal standing, is a cross-disciplinary team trained to respond to an overdose or other substance use, addiction, or mental health related crisis. These members, these teams, the coolest part about what these teams are is they're flexible for every community. We have some that are law enforcement led. We have some that are EMS led. We have some that are peer led, behavioral health led, public health led, hospital led. What it means is every community has partnerships, every community has needs, and every community figures out what's the most appropriate response for connecting individuals and families to the treatment and the supports that they need to move from the needs to recovery. QRTs are proactive. We meet people where they are. We address and listen to the needs, and we try to connect them to the services that are necessary. The model reduces duplication and makes it easier for individuals and families to access the help that's available within their community. The goal is moving them away from the emergency departments, moving them away from the justice system, moving them into community, moving them connections to partnerships that say we get the help that we need and we put them back where they want to be, and that's in their families and their neighborhoods. In Kentucky, we began working with the Cabinet of Health in 2019, and there was only a couple of teams, and I share with Chairwoman Moser in Northern Kentucky, but in 2019, we grew since then to serve over 41 counties, and there's teams working in counties that we don't even know about yet. Just in a meeting a couple weeks ago, we learned that a sheriff over in Bowling Green just started his QRT earlier this year. So we weren't aware, so we connect with those folks and figure out how to bring them into the system. So from Fayette and Lexington to Louisville to Ballard County, McCracken counties to Letcher to Breathitt to Perry, Boyd, Carter, we can go from the west to the east to the south to the north to the central. There's teams operating all across the state. And these teams come together on a monthly basis. The first Thursday of every month at 1 o'clock Eastern. Since October of 2019, these teams have gathered, and now these meetings don't just include the teams. They include Kentucky Public Health. They include Kentucky State Police. They include the HIDA teams. They include the Office of Drug Control Policy, VOA, anyone and everyone that's in this space working collectively together, police social workers and all these other partners that are finding that we can help each other and work collectively together are really working to build the support that's necessary in our communities. These meetings are a model of collaboration and the shared learning that continues to grow. Think of your QRTs or your quick response teams as a highly adaptive problem solvers. We bring together professionals from different disciplines within one community to share a common vision and a common mission to help others and help people and families move from crisis to recovery through connection, compassion, and follow-through. As we stated, we've seen incredible diversity within the QRT teams in the state of Kentucky. Lexington Fire Department, EMS, lead the state's largest with 11 members. They started with 3. They now have 11. It's law enforcement, EMS, social workers, and the community paramedicine teams. Louisville operates out of a public health department. Rural counties such as Perry, Boyd, McCracken, Breckenridge have all built strong partnerships with behavioral health partnerships and hospital partners. And again, as I stated, Bowling Green and the Sheriff's Department said, you know what we want to do? We want to lead this collaborative community response model. In Frankfort, the PD's leading the Wings of Hope QRT. That team has just started in the last year, and they're launching and they're doing great work in their communities. Together, these teams are showing that QRTs serve in communities of every size and every structure. So you don't have to be the big city. You don't have to be the small rural community. It's flexible within its own community to say, how can we respond to the needs within our community? They deliver tremendous value, but as Dr. Firesheets taught me 10 years ago when I sat in my chief's seat and dismissed phone calls from her, which says, you got to give me the data, you help me understand what this means. I get oftentimes criticized or ridiculed because I believe that success was one thank you and one hug from a family member, because when you're on the streets and you're in those environments, those things mean something. She says, in order to understand the true depth of it, you have to collect the data. And I've learned that over the years. We need to have numbers to better understand how are we serving and what does it mean? How are we making the impact? So as last year, through the support of the Kentucky Opioid Abatement Commission, we piloted Cordata's data collection platform to QRT teams serving approximately 350,000 Kentuckians serviced by the teams. The platform helps the teams plan, document outreach, the interactions, track referrals, and make sure that no one falls through the cracks. And that's a reality. We connect, it's not the 5 people we're going to see today, but it's the 1,000 people we've seen along the way. They remember us, we can't forget them. The relationships are powerful. The trust and credibility that's built within a community to say, we need your help. So when the team receives a phone call from someone that they served 6 months ago and says, I need to go to the doctor or I need a dentist, we're the people that they trusted. We never expected that, but those are the realities that are happening as these teams are working in your communities. They become the trusted entity to say, I need help, where do I go to? So I'm going to call my local QRT. It's just how it works. When every QRT uses the same system, we can begin to compare apples to apples across the state and demonstrate measurable outcomes. The reason we can say that is because we know from 7+ years in Ohio and West Virginia, we have over 300,000 interactions collected on teams being referred to people in need within their community, and we've been able to understand what it means and what these interactions really do, how they really impact the communities that they serve. We introduced that through the Opioid Abatement Commission to the state of Kentucky, and we're excited to see results and numbers come in so we can better understand what it means when the QRTs are serving the communities of Kentucky. To show what happens when this is well done, we've had some recent studies in Southwest Ohio. We wanted to better understand how are the teams impacting the communities. Yeah, it feels great. We always got good stories, but what's the data saying? So last year in Dayton, Ohio, and Cincinnati, most recently, we looked into the depth. What kind of impact are these QRT teams making? Well, in Cincinnati, we saw a 98% decrease in overdoses among people who engaged with the QRT. In Dayton, QRT clients were 60% less likely to die of an overdose. Repeat overdoses dropped by 22% in the year after clients engaged with the QRT. In Cincinnati, healthcare charges fell by $5 million a year from $28.7 million to $23.8 million for QRT clients. And in Dayton, emergency department charges fell nearly 40% from $33,000 per person to $24,000 per person. So what we see is every dollar invested in a QRT is returned back to the community. Healthcare costs are dropped by $4. And since most clients are on Medicaid, I think at one point in time we looked at that number just qualitatively as a local community. We were asking, over 7 out of 10 people were Medicaid customers. So we recognize that this is important. And those savings that we can connect to this work can come back and be part of the positive state budgets. So during my years of law enforcement, as I close here, there weren't many opportunities to be on the plus side of saving lives, strengthening communities, and then saving money. Never fit. Those 3 things never fit together. But this is allowing us to make that possible. This collaboration, this thinking differently, this operating differently, and then serving our community, helping people when they don't know where to turn, showing up, being there when they need you. That's powerful stuff. Have you ever done that and you've had a chance to get a hug or the thank you from someone that just didn't know where else to turn? It's powerful stuff. It really, really is. We know that you sit and you face difficult funding choices, but we believe this one is an easy one. Support your local QRT teams. Support those QRT teams that are working across the state of Kentucky because they're growing and they're making a difference. We wanted you to be aware of this, and we want to support them, and we want to advocate for all the great work that they're doing. So whether it's small town, big city, these teams care about each other, they care about their communities, and we just appreciate the opportunity to be here with you today. So thank you so much.
Thank you. Does anyone else have anything to add? Okay. We have had several great meetings, and I've worked with this whole team, well, Dan and Kelly for sure, for years on establishing what we recognize as a really necessary service. And we had really willing partners in our law enforcement in Kenton County in the beginning, and I'm excited to see that this is growing across the state. Can you talk about what you used, how much of the opioid abatement funds you were able to get, We understand that that's grant funding, and it's really difficult to sustain a project. And then what you're asking for.
Yeah, so I'll start, and then Kelly will lead with the overall ask. We really didn't come with a true ask today. So this is our second year in the opioid, with receiving opioid funds. The first year was roughly $750,000. That supported us building teams. It actually provided personnel, on-site personnel as well. This year we went in with roughly the same number, but we were going to increase the teams by 10 that we would support. So through our services and solution, we would support. We were asked to cut it back by 65%, so we reduced it by 65%, and unfortunately had to tell teams that were ready to start building QRTs or start to really get the process moving, because some of them struggle out of the gate to get things started because collaboration is tough. We had to tell them that we needed to reduce it because of that.
So in terms of ask, we do have a budget ask with you, Chairwoman Mosier, that we talked about yesterday, which would be $2.8 million to expand that standardized data collection across the entire state over several years, which would give a scale and volume of data that would begin to allow you to do that kind of impact analysis. Right now, obviously, if you could collect data for a year and then another year, you don't have enough to do the really good impact analysis to look at the things like Medicaid cost savings and reduced criminal justice engagement that you might need.
Okay, thank you. Senator Carroll, do you have a question?
Yes, thank you, Madam Chair. Help me understand the structure of this. So you all, and I guess I'm disappointed. I didn't realize that we were doing this in my part of the state. So it is a software system that coordinates all of this, and so the cost involved, I guess, is the use of this system, and then the services that you all provide to come into a region or a county, whatever, to set this up. Is that correct?
Yeah, it goes well beyond just the software. While we provide software, we don't look at ourselves as a technology company. We look at ourselves as a solution-based company. If you're not on the ground working with the teams day in and day out, collaboration stops, right? You may have a police chief that change, other things that change. You have to continue pushing and driving to ensure that collaboration continues. That's the services that we provide. With all of our states that we work with, we actually put people on the ground, right? So we have people in the state themselves. They know better, right? And they can report back and get things from corporate, but we put people on the ground that are training day in and day out, right? Not only on the platform, but how to keep these teams running effectively, along with looking at other grants and other things to help fund things, right, as things change, right? Dev gave a good instance of where teams are growing, right? Because they see the need and they see the impact. So we help those teams grow as their community changes as well.
So there's ongoing support. So we'll just say in my area, the Four Rivers QRT, is there a cost at the local level that the counties contribute to this? How is this being paid on an ongoing basis?
Currently, the Four Rivers team is part of the CORE, the Cabinet of Health funding. They have been since 2021, and they've been supported through the CORE on an annual basis, the CORE funding. But just as an example, there were 25 applications for CORE funding for the most recent funding year, and they funded 7. They are only able to fund 7 communities. So, and Four Rivers was a continuation of that.
Okay.
Yes, sir. Does that help?
It does. And overall, your request, that's to help pull all of this together throughout the state to really improve the services and be able to put together data that will help.
Yes, exactly. Right now, much of this work is being funded. There's a lot that's being funded through abatement dollars, locally and state. And then there's also quite a bit that's funded through federal grants, which are obviously not going to exist in perpetuity, right? They're really sort of entrepreneurial in nature to start programs, not to run them in perpetuity. But the other issue is that in having these things grant funded from different sources, there isn't a go-to place for Kentucky to see the whole of what's happening. So you might have one county reporting to one funder and the county right next door reporting somewhere else. And it's hard to really start to see the whole picture of what's going on. And obviously some communities are getting funding from multiple places. So they're doing different reports in different places. It really doesn't allow you to see that whole picture.
You all didn't really address anything about diverting folks from the court system and the added value, I guess, of that. Is that something that you all track?
We try to. That's a little bit more difficult to track. It's always hard to measure what doesn't happen as opposed to what reduces. But when we look at the reduced arrest and we look at things like reduced violent crime and reduced non-drug related crime that's associated with these interventions, I think there's good reason to believe that we're keeping people out of local jails, those short stays, and then also out of the court system.
Excellent. Thank you. Thank you, Madam Chair.
Thank you. Would you mind kind of walking us through the different components of really what you're pulling together? You didn't really address the angel initiatives, the social workers in police departments, the different components of what you're really pulling together. And what did we talk about yesterday? The not roundtable. The solution table.
The situation
table.
Yes.
Thank you. I really like that.
We came today really to educate you specifically about the quick response team, but there are actually quick response teams are an approach. You might have heard people talk about deflection or diversion initiatives, which are really designed to route people out of the criminal justice system with some accountability. So either keeping people who are kind of on the wrong path from engaging in more serious criminal behaviors or routing them out to treatment services or more effective community services with a level of accountability to keep them engaged. Kentucky right now is implementing 6 different models of deflection and diversion, including quick response teams, and the one that Dan and Chairwoman Mosier just mentioned, situation tables. The Kentucky State Police has an Angel initiative, which has been operating for several years now, which allows people to walk into any KSP post and request help. There is the Behavioral Health Conditional Dismissal Program. I assume you guys are very familiar with SB 90 and that work. There is a police social work initiative, which is where social workers work alongside law enforcement to provide care, especially for things that law enforcement gets called for that's not necessarily crime. And then there's the Crisis Co-Response Program, which is a little bit more mental health focused in nature, but obviously has a lot of overlap with a lot of these other programs. So there's actually 6 models of deflection and diversion happening in Kentucky. They're happening in different places. They're happening, some communities have more than one program. What we would love to recommend to the state is to try to begin to bring those together with aligned data collection so you can avoid some duplication, obviously, but also so you can sort of see the greater impact and start to understand which of these programs works most effectively and where.
Perfect. Thank you. Okay, Senator Herron.
Thank you, Madam Chair, and thank you all for your presentation. And I will say that Senator Carroll asked several of the questions that I had, but I do have a comment and a question. I'm very familiar with these programs. I worked with Jefferson County to set up their deflection model. Was in early conversations about why we needed it, what it looked like, and they at that time used U of L to help with the research and going and looking at different models, and we have expanded that throughout. And then this past year, I've had the honor to work with the Council of State Government on a report on these type of models and the importance of them. And I guess my question to you, and I think Senator Carroll kind of answered that, what exactly is it your role as far as the individual communities that are wanting to set it up? And then it kind of sounds like that you're wanting to, I guess my question is, what is the difference of what you all are doing and then kind of what CSG has done around these models?
So we work very closely with CSG. We've worked with PTAC, many of the PARI. There's many national organizations that are involved in this work and sort of help bring out those frameworks. And that CSG report is wonderful, by the way. It's worth looking up. We do in the state of Kentucky. We work very closely with communities to figure out how to do it there. What we've learned over the past decade is you can't hand somebody in Ballard County a report and say, okay, just go do the thing, let us know. So Dan, and I say we, it's really Dan who does that work. Will go to the community, help people figure out who needs to be invited to those initial meetings, who to bring to the table, what's the best way to structure it. We have a team that helps communities find funding. If they need to write a grant proposal, we'll help them do that. And we help them get started. And then obviously we help them collect the data, understand what information is important, and then ultimately get them to the point they can do this type of impact assessment where they can really look at more than saying I served 923 people, more than head counting, but really look at the actual impact and outcomes of this work. So we work all through that process with communities. As Dan mentioned, we've been working with some of the communities in Kentucky since 2019 through the cabinet, and we also try to convene anybody who's doing this work so that they can learn from each other and share ideas. Because sometimes, even though Louisville might be very, very different than Maysville, there are some shared problems that they can learn from each other, and so we try to bring people together in a peer cohort so they can learn.
Just one follow-up, Madam Chair, if you don't mind. When you're talking about this, do you all also have any type of legislative ideas or thoughts in which we can do as a body as well to help either inform or encourage local jurisdictions to create these teams?
We haven't, but I would love to think about that.
Thank you.
Thank you. Senator Meredith.
Thank you, Madam Chair. Just a couple of quick questions. I'm interested in your organizational structure. Are you a not-for-profit, a for-profit, private partnership?
Thank you for the question. We are a for-profit organization.
Second question I have is your ask is $2.8 million. Do you view this as a one-time appropriation? What are we buying with the $2.8 million to expand your services? And as part of that, if we do this, what's our measures of success to see we have a return on investment?
So the $2.8 million is a 3-year pilot, which will give us the opportunity to expand and enroll all of the communities that are currently acting across the state. So, and start to collect that consistent data across the state. In the rollout period, your initial measures of success are going to be set by, I think I would recommend for Kentucky to have a steering committee with representatives from the different cabinets and different departments who are engaged in this work, because you have funding requests and you got a lot of people who have a stake in this who should have an opportunity to sit at the table. In 3 years, towards the end of 3 years, you should be able to be looking at things like healthcare costs before and after. You should be able to be looking at overdose deaths before and after. You should be able to be looking at criminal justice arrests, charges, jail days before and after. The ultimate goal is to get Kentucky to the place you have a volume of data and a quality, consistent data to do those types of analysis, so you could look and know the actual healthcare costs for these individuals before engaging in these initiatives and after engaging in these initiatives.
So you don't see this as an ongoing appropriation? This is a 2-year biennial?
If the 3-year pilot worked, then and I think produce the cost savings that we really believe it will, then we would probably ask for an ongoing appropriation.
All right. Thank you, Madam Chair.
Okay, thank you. Senator Carroll.
Thank you, Madam Chair. And just one final question. Is this team, you talk about this team, and in ways there are already connections between these various groups, and maybe this formalizes it more. So Chief, let's talk about the law enforcement aspect. Law enforcement comes in contact with someone that may be having some type of crisis. Rather than taking them into custody, they contact a provider of mental health, substance abuse, whatever the case might be. You all would, I'm assuming, transport that individual to that facility. After that, what role would law enforcement have within that QRT to help this individual person?
Well, it actually depends on what that local police chief, how they want their law enforcement to be on the team. Are they, again, the makeup of Kentucky is we have sheriff's departments that have 3 people. And we've had sheriffs say, I can't be on the team, but I can be a great referral source. I can be a great partner. I can be a champion. Where we have other organizations like Lexington, where we have a police partner on the team, and part of that outreach. It's really that local conversation. But to your point, that is exactly it. First responders, community partners, engage with someone that's in need. We now have a partner and a friend that we can connect them to, rather than say, like for years, if I arrest them, the court has the connections. We'll let the court decide what's the best thing for Dan in this moment. Nope, I'm calling Kelly or I'm calling Michael because they're my mental health partners. They're my substance use partners. I have someone in need. Can we get them assessed and evaluated on what's the most appropriate step moving forward? So we're not putting them in the justice system. We're not burdening the EDs. We're not burdening law enforcement or fire and EMS. We're figuring out from the community. So we're just moving them back to the community with those partners. That is the depth of this, the quality of those relationships, so everyone understands the expectations and everyone understands that that call may come at 3 o'clock in the morning on a Sunday, or it might call on Christmas Day. But when we call, we need your help. Are you willing to be that kind of partner? That's what we've learned over time. Those partners are out there. We just never asked for their help before.
And if I might add, what these teams learn, right, when they're on the ground, they build great relationships with the community partners, right, whether it's treatment facilities or other facilities that they're going to try to get people to. They also learn which ones aren't working for individuals, right? So they know, right, because they're building the relationship with these individuals. They're now the trusted resource, right? That's why these statistics are so important, because they stop going to the emergency room for their normal, for services or stuff. They're relying on these quick response teams, right? Or they're not in the criminal justice because the quick response teams engaged. They don't want to give up on these individuals. They learn what is working within their communities, and they keep, they won't send people to places that aren't working for those individuals.
Well, that's very true. We learned the difference between treatment and quality treatment really quick.
Thank you. Thank you for the time, Madam Chair.
Thank you, sir.
Thank you. And just as a final remark or question, I guess, in this pilot, you would be reporting back to who? To us or to the cabinet? Are you envisioning a connection to the cabinet and the Kentucky Office of Drug Control Policy, or who?
I think we would take your recommendation and the recommendation of the state on that. We have worked very well with the Office of Drug Control Policy, and it's our observation that they are able to pull together various partners from across the state very effectively. So I think they would be a nice center point. I would definitely want the Office of Drug Control Policy engaged in that way.
Okay. All right. Thank you. Up. 2 more questions. Okay. We're going to speed through these. Senator Berg.
Thank you. Thank you for your work. Thank you for your mission. Can you give me an idea of how many unique individuals these QRT teams touch in a year?
That's what we want to know. You know what I mean? That's what we want to know. That's what we're learning in West Virginia and Ohio. We're learning that. We're learning that information. When you look at 300,000 interactions in those 2 states, what's that mean? That's about 93,000 individuals, specific individuals. So we're able to learn that and understand what that means and how many families that connects. So we have data from 2017 in those states. So that gives us a really good baseline, as Dr. Firesheet shared.
I think what Dan is saying is we have not been hired to collect data in the state of Kentucky, so we can't answer that question for you. we would really, that's the reason we're here, really, is because we're not able to answer that question because we don't have the ability to collect that data in the state of Kentucky. But we could, and then in a year or 3 months, we could come back and tell you how many people have been.
Sorry.
So.
Okay, Senator Nemes.
Thank you, Madam Chair. I'd like for you to clear up something that Senator Carroll brought up, and I've looked at your website and that. The way I see it is you're a software company, and these teams that are set up are great and are useful in that. And you may even help facilitate setting up the teams, and you want data so that they can help do their job, not your job. And when the calls come in, they come into these teams like an AA community or the police chief or this or that have set up teams, church organizations and that. They don't call core data. They call these teams. So it sounds like a sales pitch to me for your company to come into Kentucky and ask for 2.8 for us to do what we need to be doing. Not that it's not worth it, but it still looks a little bit like your company is selling software and you're asking us to front it, and we all look like we want to, this is cheap to set up these teams, but it's expensive to give a software company.
Thank you, sir. So you're right. We are a software company. And again, I said it earlier, right? Why we provide software, what we do is enable the teams and give them the resources and training and services and collective information on how to run effectively and how to build community collaboration. Chairwoman mentioned situation table. That's one of the things that we do. It's an accountability item, right? Because what happens in these communities is there's not accountability for a treatment facility or other facilities to participate in, certain things that are happening in the community. And every community is different, right? No community can just be handed a pamphlet that says this is the way you need to run and that be effective. We've seen it. We tried that at first, right, as an organization. That didn't work. So we partner with each of them. So what happens is the quick response team calls us. If they don't understand something, what's happening, so we enable those quick response teams. And you're right, we provide software, we provide other solutions to them to get them enabled, whether that's MOUs, whether that's legal documents to get started. So we jumpstart those processes so that they can quickly get on the ground and start doing the real work that needs to take place.
The outcomes that you're talking about are fantastic and could be fantastic. But I think this is, in my opinion, committee, this is backwards. We should be paying maybe $2.8 million to the teams to help buy your software, not to pay you software, then to go out and find teams to give it to. Thank you.
And thank you for that question. Thank you for your concerns. The cabinet did look at funding, quick response teams and mobile response, I think it was called, or quick response teams a few years ago. It was not put in the budget. I can envision this as maybe a data collection that the Kentucky Office of Drug Control Policy may want, and it may have to be through an RFP situation. I think that we need to look more closely at how this is presented. We don't typically fund private organizations or certainly name organizations when we're bringing folks into the state to provide this kind of a service. Not to diminish at all what you're doing and the work that you're doing, but I think it deserves kind of a closer look at how to really bring something this robust into the state. Okay, and we have one final question, Representative Dotson.
Yes, thank you for the presentation. And just looking at the television screen up here, it talks about every dollar spent on deflection and diversion returns more than $4 in healthcare costs. So with that being said, your ask is like 2.6, is that right? So that equates to be about 10,400,000 in savings the next year. Is that potential, am I thinking in the right direction there? Do you have numbers from Southwest Ohio where you're currently at from when you first started implementing the program to now and what those healthcare costs are?
We do, and I'd be happy to share the detailed reports if you'd like to see those.
Do you have something off the top of your head? Just kind of give us a...
I don't like to make up numbers off the top of my head because that's my research career, but Dan referenced some of them, so let me go back and look at those numbers that he referenced. But we do have two detailed reports from two different communities at this point in time looking at those healthcare costs. So what we saw is in Greater Cincinnati, healthcare charges fell by $5 million each year. So from 28.7 million to 23.8 million. And we looked at those just for reference. Those are not like an economic analysis. We looked at the actual people that engaged in this, and we looked at their healthcare cost before and their healthcare cost actual. So those are the actual healthcare costs. In Dayton, emergency department charges fell from $33,000 per person in the year before to $24,000 per person in the year after. It's a 40% decrease. And we have a lot more broken down by engagement with the QRT and the types of healthcare costs, payer source. Like I said, I'm happy to share those if you want to look at that.
Thank you.
Okay. Well, thank you so much for your presentation and for sticking around to answer all of our questions. We will continue the conversation and see how we can make some additional connections to our cabinet and those that we need to connect with. All right. Thank you.
Thank you.
Okay. Next, we have an update on the medical cannabis dispensaries. And we are going to need to be quick because we have an update on the Kratom regulations as well. Thank you. Just introduce yourselves for the record and go ahead and proceed.
Thank you, Madam Chair. Hannon Armstrong, Executive Director of the Office of Medical Cannabis. I have a couple members of my team here.
Good morning. Warren McFarland, Deputy Executive Director, Office of Medical Cannabis.
Hi, Shelby Lewis, Executive Policy Advisor, Office of Medical Cannabis.
All right, since we're pressed for time, I'll go ahead and jump right into some updates from the office. Authorized medical cannabis practitioners are our practitioners who write the certifications to our cardholders. We're currently at 493 total authorized practitioners in the state. The next slide, you're going to see a spread for where those practitioners are. The majority of our practitioners are APRNs and actual MDs. There's 78 counties represented by practitioners in the state currently, and multiple practitioners in some of those counties. Moving on, looking at the number of certifications those practitioners are writing, we're at 21,628 total certifications issued by those practitioners. Written certifications by qualifying condition. As you can see, the majority of the conditions that are being written, we have 6 qualifying conditions, and the majority of those are written under chronic pain, which is more of a symptomatic condition. So you can imagine that's probably going to be the majority of the actual certifications written. The next largest category is PTSD. You can keep going. Qualified patient applications, these are the card holders applying for cards. We're up to 15,819 applications, and we just topped 15,000 actual card holders. So that number is up a little bit. We're over 15,000 card holders in the state currently. In order to help offset some costs, because we've been in the process of getting the product on the shelf, anyone who received a card in 2025 will have the card holder fee waived in 2026 per the Governor's Executive Order 335. So that $25 fee will be waived if they get a card in 2025, and that'll carry them through 2026. Just a quick update on business licenses. And again, all this information is on our website, but we have 4 different types of licenses. And by the end of this month, we will have one operator for each one of those license types. Currently, we have 3 cultivators in the state who are actually growing medical cannabis. We'll have 1 processor by the end of next week that'll be coming online, 2 safety compliance facilities which are tasked with testing the actual medical cannabis, and then we have 1 dispensary, which I know is the focus of this discussion today, that is approved to operate. The expectation is within the next month we'll have more than 1 dispensary that'll be ready to operate. Again, that'll be based upon the actual product that'll be available for purchase. I imagine once that happens, we'll see more dispensaries come online. We have a dispensary in Ohio County, the Post Dispensary. 46 of our 48 dispensaries are in their forever homes. They've found their permanent locations. We have 2 more that are still needing to be settled, but we're working on that and should have those done before the end of the year. We have a Find Our Dispensary directory on our website where people can go and actually find what dispensaries are in their area. That's on our website currently. Here is our dispensary location spread on a map. As you can see, there's 2 that remain unsettled, but we have a good spread throughout the state that's going to make travel to these dispensaries within an hour, definitely with under 2 hours for anyone who is a card holder. I'm going to touch on some dispensary requirements. Each one of these dispensaries are required to follow our regulations. They've got SOPs and regulatory requirements in relation to conflicts of interest and their plans of operation. They have to go through us and provide all the SOPs on how they're going to be run. We do background checks on all of the employees and their agents for each of the licensees. They have to have employee badges. The facility requirements are across the board for our license type, including dispensaries. They'll have to go through local, state and local business codes for their facilities. And they have to keep proper record keeping on site. That's stuff that my team actually is able to go in and check for each one of our licensees. Facility requirements, we just touched on that, but it's the normal stuff for state and local code. They're going to look at parking, lighting, security, proper signage. Looking at security and surveillance for these dispensaries will have multiple cameras on them, dozens of cameras in some of these facilities. They're required to maintain surveillance for a certain amount of time. They'll actually have physical security on site who will be at the gate and in the facility for that. That includes the cultivators, the processors, and then even some of the dispensaries. They all have to have security and surveillance, and we have access to all that. A little bit on product safety from the dispensary side and the cultivator side. All of our licensees are required to prevent contamination. We monitor the use of pesticides and the actual chemicals that they're using. We monitor the allowable product formats, the testing. They have prescribed testing procedures that they have to follow, and we monitor any recalls. They have voluntary and mandatory recalls based upon complaints or risks to public safety. Here's some of our allowable product formats. The majority of what you're going to see in the state, as you guys know, is going to be the edibles. There will be oil, vaporization products, tinctures, and other types of product. Raw plant material is also going to be one of our products. But as you know, KRS 218B prohibits the consumption of raw plant material by smoking. That's something we're educating everyone on out in the field, including our licensees. Dispensary product displays. Dispensaries are allowed to provide examples of the product that they're going to be selling. That's pretty much the extent of what they'll be showing in the dispensaries. That product is tagged into metric. We're allowed to keep track of every one of those products. Every single plant in the state is tracked into the metric tracking system, and we're allowed to know where they are. And that includes these examples in the dispensaries. It's going to be packaged and shown to the people so that when they go in there and get ready to purchase, they'll be able to see what they're actually purchasing. Advertising and patient materials, that's another piece for the dispensaries that they're going to have to pay close attention to. They do have their examples that they're allowed to show, but they have prohibited advertising practices that they have to follow in regards to how they're going to advertise these products and where they're going to advertise them. They have labeling requirements regarding displayed on the product. They have to have certain things on the product. And then they're also provided education materials, which the dispensary people can actually educate patients on when they are in the dispensaries. We have an actual pamphlet which has been approved, which they'll have on site and be required to go through if asked, or if they feel the need, they have to go through that information with a card holder. Heavy advertising restrictions in regard to targeting minors. All these products they're gonna be reviewed by our office, and for these types of issues, we don't want to see any sort of issues with images for minors, cartoons, toys, or similar images that you might see in some hemp-derived cannabinoid products. That's not what you're going to see in the dispensaries. That's not what you're going to see on the products that are being sold in the state, the medical cannabis products. And we have the ability to look at all packages. So, labeling requirements, again, this is some technical information in regards to what's going to be on the label. The main thing is that you're going to see the THC emblem on the label for all the products. You're going to see the strands. You're going to see the list of ingredients, the name and license number of the cannabis business involved in producing the product, and then you also see the production, batch, and testing information. All this information must be displayed along with the following THC warning on the package. And I spoke about the pamphlet, which is provided to all our dispensaries for them to educate card holders on. Dispensaries licensed by the office are required to provide card holders with a copy of the pamphlet. They must retain a signature form with the cardholder's signature for a minimum 36 months as required by the statute. So these actual dispensaries have a ton of procedures they have to follow in regards to educating the cardholder, especially if they ask about what kind of product they're actually purchasing. And the majority of the licensees that we've seen and interacted with they've done this in other states, are ready to provide that information. So that is a very, very, very quick rundown of information, because I know your guys' time is very valuable.
Yeah,
so
thank you. And we do have a few questions. Just quickly, I know my colleagues are probably going to ask some of the questions that I have, but just first, why was this $25 renewal application fee waived? That seems so minimal, and I just don't understand why the governor waived that.
Well, one of the reasons was it was really one of the only mechanisms where we could waive a cost that goes on to the cardholder. As you know, this medication is not going to be covered by insurance, so they're still going to have to pay their practitioners to see them too, and that's not something that we had the ability to waive or be involved in regard to the actual practitioner fee from our office. So we were trying to think of ways in which we could cut a cost. It is very small amount, we know that, but it was something that was voiced to us through our Contact Us page and through some of the associations asking us what we could do about that fee. So we ended up just waiving it.
Okay, well, we don't do that for other healthcare, so I was curious. And then why allow raw plant if smoking is not allowable and it's not a medical delivery system?
Well, honestly, that's how the law was written. In regards to why, I don't know the reasons exactly, but that's how the law was written. So
interesting. Okay, Representative Duvall, do you have a question?
Thank you, Madam Chair. Thank you for the details today. I appreciate that. Just a question: has there been any investigations outside of the application review to determine if the applicant or license winner actually has the infrastructure, personnel, capital, available to operate on day one?
In regards to the application process, Scotty, if you want to touch on some of that. In regards to the application process and the licensing process, there were things that were looked at during that process.
Sure. In order to be issued a license, the applicant had to be eligible. And we have all our application requirements laid out in the application regulation 915 KAR 1010. If an eligible applicant was selected to receive a license and issued a license, That's the process then to become operational. The regulation has requirements that must be met before the office would approve an entity to be operational. There are several requirements that must be met. That's the process that the folks are going through now, and our enforcement division is involved in answering the questions, helping folks get to the place where they can request inspection and become operational.
Okay. Representative Sharp?
Thank you, Madam Chair. And along those lines, I've had people in my district talk about how they have rented out a residence, and people that rented that had filed multiple applications to become a dispensary under different company names. Are you guys checking for that?
In regards to the lottery process or the licensing process, or
the licensing process? They came in before the lottery process, stood up multiple companies, used one address for these multiple companies for the lottery. Now, I'm not sure if one of them had won or not, but the people that have won the lottery, are you going back and checking on that?
No, that's not something that we're reviewing at this time. We're focused more on the standing up of the actual program, but I know that has been something that has been discussed, and as regards looking at it right now, no, that's not a focus.
I would recommend considering that. Thank you, Madam Chair.
Thank you. Representative Burke.
Thank you, Madam Chair, and thank you for that efficient presentation. I have been really delighted to have the opportunity to meet several of the people who have received licenses at the different level and to be involved in the industry KCIA group. I think the thing that really sticks out to me is the feedback I've gotten from those distributors, growers, and dispensary owners is that the program we put together, they tell me, is one of the best that they've seen across the country. The thoughtfulness of the regulations, the way that this has been structured, makes them feel confident that they are able to do business in a way that is safe, it's well regulated, and they feel confident that they're going to be able to help Kentucky patients without exposing children. And I think that's important to everyone in this room. I do want to briefly speak to, because I think there was a question that you were asked that perhaps I know the answer to, and that is why raw plant material might be for sale if you shouldn't smoke it, because it will be illegal to smoke it.
Correct.
I asked the same question when I was at a tour recently, and what I heard was that people who have licenses may want to create these products for themselves so that the way they ingest it is not by smoking, but for example, they may want to make their own edible at home. They may have very limited dietary restrictions where they're not able to have the kinds of commercial processing of their food. And so they may want to make those things for themselves. So that gave me some comfort thinking that that was not the intended thing. And also the dispensary owners told me that that's not what they're going to be pushing because they actually make less money off of it. So that's all I have. Thank you so much.
Thank you.
Okay, quickly, Senator Carroll.
Thank you, Madam Chair. The child fatality and near fatality review panel met yesterday, and once again, the majority of cases that we heard were ingestion cases from children. Some of them THC. You talked about the packaging of the edible type delivery. The material itself, and I'm thinking particularly about a case we heard yesterday where the kids had access to the gummies, ate them, ended up almost died. What are the restrictions related to the appearance? And let's just with the gummies, what can they be colored? What will they look like? What's allowed?
The actual product itself, not the packaging, is the question, right?
Yes.
Yeah, those will be colored. In regards to the actual color of the gummies, that's not something that is spoken to as far as the packaging.
Terrible mistake.
Right. So, got it. But in regards to the actual packaging, it's child resistant. It requires a two-step process for the initial opening. It has a tampered evidence seal. and it's resealable, of course. But those are some of the things that are put into place to help obviously add protection for that. We're also doing an outreach in regard to our education in regards to this topic specifically, because we've been meeting with several groups, whether it's substance abuse or whether it's child advocacy, any one of those groups. We've been talking with them about speaking on this particular issue because it is something that is a concern. And we're trying to spread as much information as we can in regard to storage requirements, where this should be stored in the home, just like any other prescription medication, how it should be stored in a way that's not accessible to children in the home. So we're trying to apply that same sort of education that you would have with other prescription drugs to the medical cannabis, which has a ton of information out there. So but again, that's a great point on the actual color of it.
And I think any edible that looks like something that kids just absolutely love, we need to give that a second thought. And I guess I would alert members, and we're going to hear about this in Families and Children in November, the alarming number of ingestion cases in this state. Every meeting we have of this panel, it's obviously growing, and we're headed down the path of legalizing marijuana in this state. And I think we're going to get to epidemic proportions once that happens. So we are going to hear about that in committee. That's how much it's growing, and something we need to be concerned about, and a lack of inaction on these cases with law enforcement and social work in a lot of cases throughout the state. So it is a emerging problem within the state, and we need to be careful with this. And I have not supported this from the beginning, and I understand, and I'm okay with very limited uses, but this whole idea that we've put together, I think, is a mistake. And we need to be aware how this is affecting our youngest children in these cases, and the impacts of the decisions we're making through this. And but obviously the colored gummies, that's a huge mistake, and we need to rethink that. Thank you, Madam Chair.
Thank you, Senator Carroll. I agree wholeheartedly. I sat on that committee, the Child Fatality and Near Fatality Committee, for years, and heard much the same thing well before we ever legalized this, even for medicinal purposes. And so it is a concern. It is a reality. And now that we have normalized it in such a way that individuals feel like it's safe, they may take even less precautions. So I think that the security of the packaging and the color of the edibles, the shape and all the things that that we need to take into consideration, I think is really important. Senator Berg, did you have a quick question?
Yes, not only the color, not only the security of the packaging, it should not look like candy. I mean, some of these gummies you see, I mean, they're identical to buying like a thing of Skittles. They look identical. It has to look like medicine, because we're treating it as medicine. And if it looks like candy and it tastes like candy, children are going to eat it. It can't look like candy.
Okay, thank you. Representative Raymer, did you have a question?
More of a comment.
Okay.
When we're talking about the child ingestions, I suspect a lot of the issues we're having are also with the synthetic that are on the market that we have passed some regulations on, but I think we probably need to go back and look at the marketing and what those are allowed to look like, because those type of products aren't going to fall under them.
Yes, thank you. Even my vitamins look like little pieces of fruit. So, yes, thank you. Okay, we are really out of time, but I want to give the Cabinet a few minutes to talk about the Kratom regulations and what we are doing to enforce the laws that we've passed right now. And in my opinion, to give them time to work. I know that, Mr. Secretary, you've done quite a lot of work to really hone in on enforcement and comply with the laws that we've passed. So we just wanted a quick update, and thanks for being here.
Thanks. We don't really have enough time to adequately do this now, so I'm going to do this lightning fast. So I'm concerned.
Introduce yourself for the
I'm
record.
sorry. I'm Stephen Stack. I'm the Secretary of the Cabinet for Health and Family Services, and we have Miss Julie Brooks from
Thank
the
you.
Department for Public Health.
Yes,
So
thanks.
the legislature and the executive branch have been very active on these topics in the last couple of years. And so and I hope you'll share this slide deck with the rest of the legislature, and I hope I'll have a chance to testify at other places where we get a bigger audience. So starting in 23, legislature sent all the regulation of hemp-derived cannabinoids to DPH, and then over 24 and 25 made numerous changes related to vapes, cigarettes, nicotine, and also cannabinoid beverages. So it's been shifting a lot in the last few years. In 23, we were directed specifically to regulate the hemp-derived cannabinoids. We have had 2.5 years of continuous regulation. Unlike alcohol and nicotine products, there are no FDA oversight for these things. There are no national standards. This is boutique work that varies specifically from state to state. We had to build from ground zero an entire infrastructure, a whole new team with new competencies that nowhere in state government did that exist. And we've been doing that. So we were told to immediately begin regulating hemp-derived cannabinoids. That Bill 544 had an effective date July of 23. 1 month later, we put our first emergency regulation out, and we worked for 2.5 solid years. And that's why I put all this in here. There have been legislative hearings for reg review and other laws throughout this 2.5 years. The most recent and last regulation we needed, the biggest one in some ways for the retail space, was just approved in February of this year. So 7.5 or 8 months ago. So a lot of work. So what have we done? So the products, all the intoxicating products for hemp-derived cannabinoids now have to be regulated. All unregistered products will be prohibited from sale. We do all this information gathering for the businesses to ensure we know who we're regulating and that we have tabs on it. And there's mandatory third-party testing. One of the problems is you don't know what you're buying. So you have to know that at least what's on the label accurately represents what's in the container. So we're doing a lot of those things and making sure the solvents and all the other stuff that's not supposed to be in there are tested and not in there. In the retail space, we do all of this stuff. We prohibit intoxicating sale to minors, prohibit plant material sales. There's other laws for that. We have labeling requirements, child-resistant packaging, consumer warnings, testing limits, record keeping, and you can't just put all this stuff in food in the state without following specific regulations, because people would go and get thoroughly baked at a multi-course meal with people putting all this stuff in there. And I think the legislature's been very concerned about this, appropriately so. For retail inspections, look, we're not wanting to be hostile to businesses. We want to educate them first and give them the chance to come into compliance. So we lead with education since all of this is new, but we also enforce when there's non-compliance or they're in violation. So for the retail sites, we collect all this type of information, verify the stuff on the shelf fulfills the labeling requirements, and they can only sell registered products. We've done so much work on this that just this February, the National Cannabis Industry Association said, quote, Kentucky's hemp program stands out as a model of safety, transparency, and innovation due to its prioritization of registration and rigorous testing of hemp products, and it goes on. We worked with industry, and industry has sat at this very same table with me and complimented the work we've done because we worked in partnership, but we have also put in very significant standards to try to protect people in Kentucky. So here's what we've done. Just since February, March of this year, we've reviewed over 1,200 submitted product registrations. We have only approved 30%. We have denied half of them for failing to comply with these requirements. So we are beginning now, just the beginning, it's tip of the iceberg, beginning to apply standards, and we've still got 20% of these almost that we have to still review. Look at how big this industry is. I estimated there could be a couple thousands. We're right there. There's already almost 2,000 retail sites permitted to do this stuff, and we still get 40 or more new permits each year. I'm almost done here. So we've done enforcement too. We've inspected at this point, because this was through September 30th, more than 500 retail sites. We've embargoed, meaning we've cordoned off and said you may not sell this. It has to be removed from the floor and returned to your distributor or destroyed. 191 different products. We've issued cease orders. We've suspended a permit. We've even gone to court on one who would refuse to comply and got an injunction against them. And in some instances, we partner with local law enforcement when there's an immediate need to seize and destroy product. And so we've been very active in this, and this is just about 6 to 7 months worth of work, folks. So the work that is wanted is being done by a specialized team that didn't exist and had to be built. And you remember that 544, it was the Kratom, which I'm getting to right now here, that was on the list of one of the things we did not have an appropriation for to do. We now have a team. We have retail permit fees. We have now identified the revenue source. Each of those sites has to pay a retail permit fee. And so we are now in a place where we have a structure and a framework already built for hemp-derived cannabinoids, and we have a revenue source. And so now we are able to start doing this work on Kratom because those things work together. It's the same team, same skill set. So Kratom itself is an unregulated herbal substance from Southeast Asia. It has opioid-like effect, and in fact, under Kentucky law, it actually qualifies as an opioid. Kratom has 2 main chemicals, mitragynine and 7-hydroxymitragynine. The one that gets the most attention is 7-OH, 7-hydroxymitragynine. It is wicked potent, ultra-concentrated, addictive, creates withdrawal symptoms, neonatal abstinence syndrome. All sorts of bad stuff happens with that. The 7-OH is way more potent. It's present in the natural plant, but only in scant quantities. This is just like the hemp-derived cannabinoid stuff. Organic chemists or kitchen chemists, bathtub chemists, synthesize this stuff, or they hyperconcentrate it, and they make it wicked strong, and it causes bad stuff to happen to folks. It is not approved by the FDA. Dr. Marty Makary, who I just saw in D.C. yesterday, has been on the record along with others about this stuff needs to be regulated and overseen. In 7 or more states, it's been outright made illegal. Kratom and all of it. And so this is an area where there's a real need for specialized team and expertise to do this work. Both the FDA and the Drug Enforcement Agency have issued public cautions on Kratom, and we were given legislatively earlier this year an encouragement for the Office of Drug Control Policy and Department for Public Health to issue a public awareness statement about the dangers of 7-OH and Kratom, which we did. Now there's a tension here because the natural, if you will, the natural Kratom community doesn't want these prohibitions because they say natural Kratom's not as dangerous, but I refuse as a physician and in my health role to give the false assurance that any of it is safe when none of it is regulated and no one has any idea what they're getting. But they are absolutely correct. 7-OH is far more dangerous than people using the natural plant. So we're almost done here. So in 2024, House Bill 293 assigned Kratom regulation to the Department for Public Health. It already prohibits sale to people under 21, and it already has limits on 7-OH content. We just created this drug and supplement branch. We're doing all this work with the hemp-derived cannabinoids. We have built a coherent regulatory framework that has had industry support to be rigorous and aggressive about making sure that we regulate these things. We are now ready and poised to be able to do the Kratom version of that and have the same permit fee for retail, allow people to sell multiple substances, but all be overseen by that same team. So again, we're not trying to be punitive to industry, but we are trying to protect Kentuckians and follow the intent that the legislature has given in law. I guess if I had to leave here with one ask, and this is the final slide, we're doing the work that the legislature wants. And I would ask those of you who are still here to encourage your colleagues to watch this video and to communicate with each other and share this slide deck. My biggest concern is there's not enough shared understanding, so we're not on the same page. And so these different committees create different bills, and then we start pulling different directions. We're doing the work, and we're poised now to ramp up. And I think that we can all, this is an area where executive branch and legislative branch, we're aligned in what we want to do to promote safety and protect the public. And I hope this gives you some assurance that a lot of work has been done over the last few years, but we had to first build a whole new framework from scratch, get a revenue source, and now move forward. So now we're at the phase where we're going to scale and make it better. And the last thing is the new public health lab that designing now and we'll break ground on, we hope, next summer. We're building a dedicated laboratory in there so we can spot test ourselves some of these contents if we take it off the shelf. So, Representative, that's the end of this report.
Okay, thank you so much. And you and I have had many conversations about this, and I know the work that you're doing. I really appreciate all the work that has gone into creating an office, really, I guess it's an office that is really going to oversee this. So I am with you. I will tell all of my colleagues to please watch this. I know that you've had some meetings with some of our colleagues who have concerns, and we're considering other, laws to stiffen the enforcement. I think we are doing it, and this is one of those cases that we just need to let it play out and do the work that you've put in place. Senator Mills, do you have a question?
Just quick feedback. You spoke to it, and thank you. That's more information than I've gotten on this subject in the last 5 minutes than I've been asking for a year, so thank you. Obviously, the enforcement is still unequal, uneven across the state. The gas station I fill up at when I head out of town, it doesn't look like a convenience store anymore, and I go in and ask. And he actually said that he is taking everything off the shelf that he's supposed to have off the shelf. It's cost him over $4,000 a day. But he said right down the street, 3 other people are selling the stuff still. So that's frustrating for him, a law-abiding person, and it sounds like y'all are heading in the right direction to get equal enforcement across the board.
I share that frustration. It really is just all about you had to start somewhere. And we're moving. But I agree. We want to make it uniform and equal. That's the only way it's fair. And so we agree with that.
Okay. Thank you. I apologize for having you on the end of the agenda. It does not diminish at all the importance of what you're working on. So thank you
very much.
Yeah, thank you. Okay. We will be meeting next on November 12th at 3 p.m. in room 154 of the annex. So just take note of the time change, and this is the interim, and we're moving into crazy holiday time, so things are changing. And I appreciate everyone's attention today, and we are adjourned.